Today we are going to discuss the access technique. Access is the key of success. The definition of the access technique is that in minimal access surgery, technique of entry inside the human body with the telescope and the instrument is called as access technique. It is entering inside the human body, because access will be different for different surgeries. Like for totally extraperitoneal hernia surgery, access will be different. For hysteroscopy, access will be different. For laparoscopy, it will be different. For thoracoscopy, it is different. So, it is a minimal access surgical procedure to enter into the abdominal different cavities or human body with the telescope and instrument. There are two types of access. The first access is either closed or open. Closed access is by the Veress needle, and open access is with the help of the Hassan's technique or direct entry. That is a mini laparotomy. Some surgeons, they practice the blind trocar insertion, in which they neither use Veress needle and nor they do the open technique, they directly introduce the trocar. That should ideally be avoided, because the incidence reported is 2 to 4% of the bowel injury is the incidence in the direct trocar entry. So, before access, you should anesthetize the patient, you should check for any lump, there should not be any lump in the abdomen. If the bladder is full, you should put a Foley's catheter. Then you do the white balancing and focusing, white balancing with a white object, focusing at a distance of 10 or 5 centimeter. If it is 10 mm telescope, then 10 centimeter, 5 mm telescope means 5 centimeter at the focal length. So, the appropriate focusing should be done outside, and after that you will see that your patient is prepared or not. Urinary catheter or nasogastric tube should be allowed if there is any operative procedure. If it is just diagnostic or simple operative, you may not use it, but using it is recommended. Like suppose you are doing total laparoscopic hysterectomy, then if the catheter is there, bladder will be empty, and then you can easily separate the UV fold. There will be less chances of injury to the bladder. Exactly, if you are doing fundoplication or any upper abdominal surgery, even simple cholecystectomy, using the nasogastric tube has the advantage that the stomach will remain collapsed, so that visualization of the colored triangle is better, you can see easily. So, that is why you should use it appropriate urinary catheter or nasogastric. Patient should be, regardless of the procedure which you want to do, patient should be head down, that is Trendelenburg position, that is 15° head down. And then there are 5 sites of access. When you want to do the access, there are 5 sites which is possible. What are those sites? I am going to discuss. So, the first site which is used for access is supraumbilical. Let us take an example. If this is the patient and here is the this is the diaphragm, and here is the umbilicus. Then one of the site is supraumbilical. Supraumbilical site is used for all the upper abdominal surgery, like if you are doing fundoplication, gastric banding, all the other bariatric procedures, then you will use a supraumbilical port. Ideally, it should be 22 centimeter below the GP sternum. This is the distance. Another port is called as infraumbilical, that is 3 to 5 centimeter below the umbilicus. Infraumbilical port is very popular for the gynecologists who do the single puncture sterilization in the camps. They do not go through the umbilicus, they go 2, 3, 5 centimeter below the umbilicus. It is also used for pre-sacral neurectomy.
How much from the umbilicus?
That is 3 to 5 centimeter below.
But umbilicus is not a fixed point. You have to move from the
Yes, that is why umbilicus position is not fixed. That is why in the general surgery we have to calculate from the Giffey sternum, but in gynae procedure you do not have to calculate from Giffey sternum. In gynae procedure it may be 3 centimeter below the umbilicus directly, because your target is the pelvis. So, in gynae procedure only 3 centimeter below, and it is only used for the simple procedures like Luna, presacral neurectomy or sometime sterilization, that is all. It is not used at all for the hysterectomy or the ovarian cystectomy. Now, over the umbilicus you have 3 sites. One is called as superior crease of umbilicus. This is superior crease of umbilicus. This is called as crying incision, because it is just like a crying face. Another is called as inferior crease of umbilicus. This is called as a smiling incision, because it is just like looking like a smiling face. And the fifth is transumbilical, that is along the deep pit of the umbilicus. This is transumbilical. So, supraumbilical and infraumbilical is not generally performed in the routine surgery. It is only in the some of the specialized procedure, but around the umbilicus we use maximum, because central location of umbilicus and ability of the umbilicus to hide the scar makes it the most attractive site for the primary trocar insertion. But among all these, all 3 are umbilical. Among all these 3, smiling is best. Do you know why? If you will see the layers of the abdominal wall, then this is a skin, this is umbilicus, and below the skin you have subcutaneous tissue, then you have anterior rectus and then posterior rectus. Posterior rectus is only up to here, and below the posterior rectus you have peritoneum. This is peritoneum. In between the all the fat, maximum fat is in between the anterior rectus and skin. All the fats are there in between, and muscles are in between these 2 rectuses. This is muscle fiber. There is one vitreointestinal tract, there is a duct. This is called as vitreointestinal duct, or it is also called as umbilical tube. This umbilical tube is present in every human when we are in fetus that time, because it is joining the intestine of the fetus to the umbilical cord of the mother. After 7/8 month of the gestation, it started ovulating, and then it get disconnected, but still the cell intelligence of this area, this ovulated umbilical tube is still present in everyone, and cell intelligence of this area has a spontaneous closing capacity. Do you know, in our body every cell has its own intelligence, that the liver cells has its intelligence to regenerate, a skin cell can regenerate, the muscle has a capacity to hypertrophy. So, this has a spontaneous closure capacity, and if you will put a trocar, like if you are putting a trocar from this vitreointestinal tract, you are not going to the thinnest part of the abdominal wall. Transumbilical has a problem that this is the thinnest part of the abdominal wall, and if you will not close the rectus, there is a potential risk of hernia. But if you are going, this idea was given by a Scandinavian surgeon, that is why it is called as Scandinavian technique. And if you will go through this, you will not have any problem, and there will be no any chances of hernia in spite of not closing the rectus sheath. Because once you go oblique and you take the trocar out, automatically this umbilical tube will close. Umbilicus has one drawback, that it is a dirty part of the abdominal wall. It has a high load of Streptococcus epidermis bacteria and the other bacteria also. Because of confluence nature of the skin, debris are always present here. That is why when you are taking shower with the soap, you want to clean the umbilicus always, because umbilicus is a naturally dirty area. It is pitted area, it is confluence skin, corrugated skin. So, if you will go through the umbilicus, there is a possibility that infection will be more and hernia will be more, because it is thinnest part of abdominal wall. That is why going to the people, they say that if you will go to the smiling incision, you will keep on smiling, and there will be minimum chances of hernia or infection. Another important advantage of going smiling is that suppose you have to enlarge the incision also, like in the single incision and all, then also if you will see diameter of the incision is only 10 millimeter, but actually it is 20 millimeter. So, if you will make it circular like that, and if you enlarge, it is actually 20 mm, but as soon as your work is over, your trocar is out, again it becomes 10 mm. So, it has a great capacity to hide the scar. Nobody can tell the patient that till laparoscopy was done, if you will go through the inferior crease of umbilicus, and that is semicircular smiling face like incision. Some people they give vertical incision here also. Vertical incision also is not a problem, but only a disadvantage of giving vertical incision is that a scar will be visible, but going through the inferior crease, a scar will not be visible. So, these are the few of the attractive side of the port position, which you have to use either inferior crease or superior crease of umbilicus. Veress needle should always be held like a dart, and the appropriate amount of the tip of the Veress needle should be naked. You should also check the spring action and the patency test of the Veress needle, either you or you trained your nurse that before use, because sometime if it is blocked or a spring is defective, then you are in big trouble, it can create the injury. After that, you should take 2 LEs forceps either side, and with 11 number of knife, you should give a stab wound over the inferior crease of umbilicus. Some people initially only they give 11 millimeter incision. Ideally, it should be avoided, because initially only if you will cut 11 mm incision, or if you will cut the rectus, or you are going too deep, then your quadromanometric indicator will not be good, because 50% of the gas is leaking outside, and that will not help you to decide that minimum amount of the required gas is filled up in the abdomen or not. So, even 8 liter of gas will go inside, but your abdomen will be still not distended, because 50% of the gas is leaking. So, that is why initially we should give only 2 millimeter stab wound. After that, you should check the Veress needle and lift the abdominal wall holding below, and we should lift it in such a way that angle between the abdominal wall and the Veress needle should be 90 degree, and angle between the Veress needle and the body of the patient should be 45 degree, and then you will go towards the anus. ALIS should not be used to lift the abdominal wall. Purpose of ALIS is just to evert the crease of umbilicus.
Okay, so you remove it and replace that one or?
No, till the Veress needle till has introduced, it should be there, because everted umbilicus is required at that time. So, here is the ALIS is attached, but it is not used. Never use the skin Kelly's clamp or towel clip to lift the abdominal wall. Some people they use it. Towel clip or Kelly's clamp is bad because it will stretch the skin and it will make a distance between the rest of the abdominal wall from the skin. Our purpose is to make a distance between the bowel and abdominal wall. Our purpose is not to only lift the skin, our purpose is to lift the entire abdominal wall, and then you will enter. So, how to do? We can see here this video, 2 LEs forceps are applied, and then this is the knife giving the stab wound, only 2 millimeter stab wound with 11 number of knife, do not use 15 number of knife. And then take the Veress needle, lift the abdominal wall. If very obese patient, then ask any assistant to help you, and then it is perpendicular and 45. So, once you will go 1 and second click. So, again we will see lift the abdominal wall and then hold it, point towards the anus and 1 and 2 click, you are in. Then you will do irrigation, suction and hanging drop test. Hanging drop test is most important, which will let you know that you are inside the abdomen. As soon as you will lift it, the drop will be sucked in, that means you are inside the abdomen, and after that you will attach the tubing of the insufflator. Once the tubing of the insufflator is attached, after that you will get a quadromanometric indicator, that is preset pressure, actual pressure, flow rate and total amount of gas used. This has a lot of information for you to let you know that where your gas is going. What are those? Insufflator has the information I have already discussed yesterday. On Saturday I do not have to discuss this more, but as I told you that the length of the Veress needle should be 4 plus thickness of the abdominal wall. Why? It get tented. You can see here, this is tenting of the Veress needle, and after that much tenting, now it is punctured. As soon as Veress needle is punctured, peritoneum is returned back, and now this is the blunt tip coming out. And the advantage of this blunt tip, that even it will touch the any of the bowel, it will not get injured, and it can be safely used. So, this is very good. Another direction should be towards the anus. If you go towards the anus, what are the advantage? That your vertical entry is 50%, horizontal entry is 50%. Due to halosacral curve, more room into the pelvis. Sacral vertebra does not have vertebral body to give the counter, and aortoiliac axis is 5 centimeter above the sacral promontory. There are 3 exceptions in which we should not use oblique. One is directly going to the diagnostic laparoscopy under local anesthesia. Another is morbid obese patient. In morbid obese patient, you cannot go towards the anus, you have to go perpendicular. And third is any lower midline surgery, incision. Another important thing is that if you have a habit of going perpendicular, do not keep the patient head down. This is bad, because if you have a habit of going perpendicular, if the patient is head down, all the bowel will move just below the umbilicus. So, you should keep the patient supine flat, and then even going it is safe. Now, indicators, this is the obese patient and it is going perpendicular here. This is supraumbilical port, from GP sternum it is 20 centimeter below, and then you will get 1 click and second click, and then this is a syringe. You will do irrigation, then suction, and then hanging drop. And it is sucked in. So, this is called as quadromanometric indicator at the end. Some people they use the needle movement test. Needle movement test means after going inside, if you move the needle, if it is in the free space, it moves freely, otherwise it gets stuck. but many people they do not recommend needle movement test, because suppose we are in any aorta or vena cava, it can lacerate, it can tear up. Now, this is irrigation, then you will do suction and then you will put few drop of saline, and this is hanging drop which can be sucked out. In spite of that, if you have little doubt, you can do plunger test. In that you can take the piston out and then column of the saline which was in the syringe, you will get empty. Slow and careful insufflation is required. You should keep a oblique hold over your needle, otherwise sometime accidentally needle is pulled out or tip of the needle is touching the wall of the omentum or bowel and it gets stuck. So, for that we have to be little careful. Now, for primary trocar insertion, you will also extend the incision now to 11 millimeter. This is important. One of the most common cause of forceful entry inside the abdomen with the primary trocar is the small skin incision. Because we want to become cosmetic and initially our incision was 9 mm or 10 mm, it should be 11 or 12. So, one of the most common cause of forceful entry inside the abdomen with the primary trocar is a small skin incision. And then you are pushing it and the margins of the skin is getting completely undermined, it is getting bulged inside, and after that it make a tight hold dry skin around the cannula. So, extend the incision up to 11 mm, spread the fatty clamp and open the vitreointestinal tract which was present in the fetal life. Just like the bird which digs the tree, you should keep on going with the help of the artery forceps, you should try to bifurcate the obliterated vitreointestinal duct which was present, and then you will enter into the abdomen. Hold the trocar like a pistol, head of the trocar should rest over the thenar eminence, middle finger should wrap around the air inlet and index finger should be pointed towards the sharp end. Cannula has a two finish, this is dull finish, this is shiny finish. Dull finish is inside the abdomen because it will not reflect the light. Your index finger must reach up to this half of the dull finish of the cannula, and then slowly you will enter into the abdominal wall by rotatory movement, screwing it. Only thing has to be taken care that screwing should be perpendicular to the abdominal wall. Sometime some people they use blind trocar insertion, like here you can see that this is a blind trocar insertion. This is a multipara omen and abdominal wall is lax. So, you and your assistant both can lift the abdominal wall in such a way that angle of the abdominal wall and the trocar should be 90 degree. So, this is not correct, you have to make little more oblique like that and this way. So, this is and here this is 45 degree. So, this is blind trocar insertion, and then lift it and screw it, and screwing should be on the axis, it should not make a arc, on the same axis, and right left right left right left right left right left you will enter into the abdominal cavity, and a smooth entry, no jerk, and it is in. So, forceful entry is one of the chance to get the complication faster. If you are using disposable bladed trocar, then you should enter in one go, you should not screw, because disposable trocar has a blade. So, if you screw it, it will get discharged in the halfway, but if you are using a reusable trocar, then you should go screwing. Reusable trocar, metal trocars should go screwing, so that you can enter easily inside. So, this precaution has to be taken. Now, once you have in, then audible click, hissing sound and loss of resistance, all three will be visible. So, we can see here again how to put the trocar. Skin incision is enlarge and the trocar is held like a pistol. This is 5.5 millimeter and then hold it and go screwing and you are suddenly giving the sensation you are in. Once you are in, then first you should inspect the viscera just below the insertion to inspect any injury, and few drop of blood always you will see, that is a trickled blood through the umbilical wound. We should not get panicked by seeing this wound that, oh, I have done some complication, and then you should inspect and put the other trocars. Other trocars, whenever you are putting, you have to do the trans illumination. Where to put the secondary trocar, that I will discuss separately in the baseball diamond concept of port position. But for now, I just want to tell you, you have to introduce it completely, taking care of that it should be no any vessels in inferior epigastric vessels should not be below, and the secondary trocar also you should just cut the skin only, rectus should not be cut, and initially it should go perpendicular, and then as soon as the tip of the trocar is anchored by the peritoneum, then oblique, so that it should not make a track, and the skin incision and peritoneum incision should be in the same line, it should not be going away. This is important when you are putting secondary trocar. Now,
what's the distance between it and the midline?
Distance from the midline is not important, distance from the target organ is important.
No, you see, for entrance to avoid injury to the inferior epigastric artery, some distance.
No, inferior epigastric artery distance, it depends, distance is you have to see the trans illumination. Trans illumination, put the light cable down and you can see the trans illumination. I forgot it today to show you. Tomorrow again we have one surgery, so I will demonstrate you that.
Also, others saying that it should be considered the ascending branch of deep circumference iliac artery sometimes who is trouble bleeding.
That is true. So, for that people are saying that it should be 3 millimeter, 3 centimeter medial to the anterior superior iliac spine, not more than that, but generally we do not recommend it. Do you know why? Because it is never fixed. If I do not need to be there, then why I will put it there? Suppose your uterus is 24 week size and then you are putting too low, then it will not work. So, in those situations sometimes we have to put all the 3 ports in the same line, one in umbilicus, or sometime umbilical port also has to go supraumbilical. So, we will not put our port just due to the fear of inferior epigastric vessel. We will consider definitely the inferior epigastric vessel, but we will put our port according to the baseball diamond concept of port position, that I will discuss to you. So, this is.
So, the line of incision, the secondary trocar, that should be some perpendicular to inguinal.
No, it should be in the Langer's line. Langer's line, that is a skin crease, so that a scar won't be visible. Langer's line of this area is like that. Yes. So, parallel to the inguinal ligament, so that the scar won't be. That is why even the appendix, when you are doing the surgery, you are giving the incision in the Langer's line same way, so that a scar won't be visible. Anywhere you give the skin incision to the laparoscopic port, you should respect the Langer's line, and according to that you should do it, not only in the right and left iliac fossa, even the epigastric or right and left hypochondrium we use the same. Now, you will put the trocar and after that you will start putting your cables. When you are attaching your cables, you must take care that cables should be attached in such a way that the camera cable and the monopolar or bipolar cables should not be intermingled with each other. Otherwise, whenever you will press the electrosurgical paddle, the monitor will get flickered, flickering of the monitor will occur. So, this must be taken care, and camera cable should be away. After that, you will do a diagnostic laparoscopy and you will start doing the surgery. Now, some of the contraindication of umbilical entry. If there is a previous midline incision, if there is a portal hypertension with the recanalized umbilical artery, and if umbilicus itself is disease, like there is a umbilical hernia, umbilical cyst, infection of the umbilicus, umbilical sinuses, then umbilicus should not be used for the access. In those situations, you should use Palmer's point. Palmer's point is the most attractive site of the entry once the umbilicus is in trouble. Whenever you think that I cannot use the umbilicus due to one or another reason, then you should use Palmer's point. Palmer's point is very good and attractive site, that is a mid clavicular line just below the costal margin, and this is the point here, and this point has many advantages. One of the advantages is, in spite of having a lot of adhesion in the abdomen, this area is almost always adhesion free, because stomach is a good organ, it always inflate, deflate, does not allow any fibroblast and collagen to grow. Second advantage is the costal margin is keeping this area lifted up. Third advantage is stomach is a beautiful organ to perforate. Stomach is perforated, and if you will perforate the stomach, there will be absolutely no problem. Do you know why? That is why transgastric cholecystectomy you can do. In women you can do transvaginal, but in male you have only two options, either transrectal or transgastric. So, transgastric is better than the transrectal. Like if you will see here, and you will see in this is a stomach is getting perforated. Here this is a stomach, and this is a stomach is perforated purposefully by the electrosurgical cautery, and it is perforated now. And now you can introduce the endoscope through the stomach, anterior wall of the stomach. This is pylorus, and here it is going, and now it is inside the abdomen. This is liver, this is falciform ligament, and now you can do cholecystectomy. So, this is transgastric. So, many surgery is possible transgastric. That is why I am telling you that stomach is a good organ to perforate, and even if it is perforated accidentally by your Veress and Trocar, you do not have to care, just put a nasogastric tube, keep on intermittent aspiration, it will spontaneously heal, because stomach has one oblique layer of the muscle which has a great capacity of healing its own. And even if peritonitis happen due to stomach perforation, always only chemical peritonitis happen. It cannot do the bacterial peritonitis, because stomach does not have bacteria, and chemical peritonitis can be easily controlled by giving high dose of proton pump inhibitor. I am not saying to perforate the stomach, but what I mean to say is perforation of the stomach is better than perforation of colon or perforation of rectum and others. So, that is why notes is performed transgastric. Only contraindication of this Palmer's point is if there is a splenomegaly, then you will not use it. So, you have to take one 11 numbered knife, and then you put the one mosquito, then you take a Veress needle, and then you introduce, then you do suction, irrigation and hanging drop test, and then you put the Veress needle insufflation, then you take a trocar, and trocar should be just pointed towards the stomach. It looks like that you want to perforate the stomach. So, it should be directly pointed towards the stomach, and after that you will enter inside, and then you will put a telescope. If you are a gynecologist, you cannot do TLH keeping your telescope in the Palmer's point. So, what you will do under this vision of this telescope, you will put another trocar into the umbilicus. So, that now you are under vision. So, you are safe, either umbilicus or supraumbilical, depends what you want to do. Another important thing is that if you are a gynecologist, simple surgery like simple ovarian drilling and all, you can continue from Palmer's point itself, but TLH and all you cannot be able to do, because you cannot see the vault, you are far away. So, that is why in those situations you have to use it only for access. Light cable should be down. If you are doing ventral hernia, then now you can do ventral hernia by putting other two ports, and you can perform almost all type of hernia you can do by this, even the huge hernias, or you can perform. In ventral hernia surgery, Palmer's point is the ideal site for the primary trocar insertion. This is important, this has to be used. So, this is one of the important thing which we have to keep in mind, that the contraindication of the umbilical wound is the splenomegaly. And another important thing you should have to be considered, that contraindication of umbilical entry is, these are the points, that is the portal hypertension and umbilical sinuses and umbilical abnormalities. Now, open technique. What? In portal hypertension, umbilical arteries are recanalized and then severe bleeding starts, because whenever portal hypertension happens, all the obliterated arteries of the body get recanalized, and that is why you should not use it. Now, why open technique? Because blind is blind. In Veress needle technique, we are assuming that there should not be, it is good there should not be any adhesion, but it may not be true. Patient might have got one typhoid fever when patient was 3-year-old, severe gastroenteritis, it was just about to perforate, anyhow it was sealed, but it has adhered with the umbilicus, and 3-year-old child never remember what happened. At 30 year of age group, you will ask that do you have any severe illness before, she will say that no, or he will say that no, and you put your Veress needle, directly it enters into the bowel. Our patient has Cox abdomen when she was or he was, and treated by the antitubercular, there was miliary tuberculosis, extensive adhesion all over the abdomen, and our trocar. Patient was having aortic aneurysm, which patient does not know. An ultrasonologist has just given you the report about ovary, he has not explained about that aortic aneurysm, and our trocar can directly puncture that aneurysm. Patient may die on the table due to aorta rupture. So, open technique is better, especially for the people who have started doing surgery in the beginning, and it was first demonstrated by the Hassan in 1974. That is why it is also popularly called as Hassan's technique. Hassan has reported it. It has a cone over the cannula, and it has a plastic or metal blunt trocar, blind tipped blunt trocar, and this is a cone. Why it is a cone? So that even if your incision is big, it will plug, and gas will not leak. So, Hassan technique, what you have to do? You have to cut the skin below the umbilicus transverse, and then take 2 bites over the rectus, one bite towards you, another bite towards your assistant. Hassan technique is not done on the transumbilical region, because at the level of the transumbilicus all the layers are fused together. So, below the umbilicus you will give a transverse incision over the skin. Some people they give longitudinal also, but in the skin if you will give transverse incision, in the rectus you have to give longitudinal incision, and in the skin if you will give longitudinal incision, then the rectus you have to give transverse incision. So, here a skin is cut, this is a skin, this is retractor and this is rectus, and two bites are taken over the rectus, one bite this side, other bite that side, and then lift the rectus up. Once you will lift the rectus, a bridge of the intestine will stand up, and with the 11 number of knife you will cut it longitudinally. You will cut it longitudinally, and after that you take a scissors or mosquito and you try to bifurcate the layers, and you should try to puncture the peritoneum bluntly. Blunt perforation of the peritoneum has to be done, and you will enter into the abdominal cavity. Then you take that Hessian cannula and just fix the suture which you have taken on the rectus, will be used to stabilize the cannula also, because this cone shaped cannula has a tendency to come out repeatedly. It is not fully tight because it is open technique. So, you have to stabilize the cannula. Other trocar will be same like pyramidal trocar, and other trocar will go the same. Hessian technique is only used for the primary trocar, that is optical trocar. Sometimes you can put your finger, this is one of the great advantage of Hessian technique, that your finger can feel all around the adhesion and you can break the fibers. And then you can put the trocar, and you can the same suture which you have used to use for stabilizing it. So, Hessian technique is especially beneficial for people whom you are thinking of extensive intra-abdominal adhesion. This is a modified Hessian technique where the skin incision is given longitudinal, and after cutting longitudinally below the umbilicus, longitudinal skin incision is given, and then you can just with a gauge piece you can clear the fat, you can separate the fascia by scissors opening the jaw, and then you can hold the rectus by a cocker. And then lift the rectus up either side, right and left, this is rectus. And because a skin incision was given longitudinally, so rectus incision will be given transverse, horizontally. Because you cannot hold it, if a skin is longitudinal, you cannot hold the rectus transverse. If you have cut the skin longitudinal, then you can hold the rectus longitudinal, and if you will hold the rectus longitudinal, you have to cut it transverse, and here it is cut transverse, and then by opening the jaw of the mosquito you are in, and then you can take a S clamp, a small S shaped clamp. Rectus bite is important, either you do in the beginning or you do at the end, because you have to stabilize the cannula, and this is the open technique. Here omentum is visible, and in open technique you have to use blunt tip cannula, that is Hessian cannula, which has cone shaped. You have to adjust this cone up or down according to the thickness of abdominal wall, and you can adjust, and then you can tight it here. This is the knob to tight it, and then you can drop this blunt tip trocar, and the same suture which is taken over the rectus will be wrapped around to stabilize the cannula, otherwise gas will leak. Hessian technique has one of the biggest advantage, that any time in your life you will never ever damage the aorta or vena cava, because how can you damage the aorta if you have not used any Veress needle or any sharp trocar. But as far as the bowel injury is concerned, Hassan technique sometimes create bowel injury. If the bowel was directly incarcerated with the rectus, then even in the Hassan technique sometimes bowel get injured, because you will cut the rectus and you bluntly perforating the peritoneum, you will enter into the bowel. So, at the end, the same suture which was taken to stabilize will be used to close the wound, but what you do, you cross it. Right will go to the left, left will go to the right, and then tie a tumble square knot. This technique we will learn also in the lab. This is called as tumble square knot, and it is crossed. Right is going left, left is going right, and this is tumble square knot which can slide directly. Now, it is tumbled and you cut it, and now it will slide its own, and then you can pull it. So, this is the same suture which was used to lift the rectus is now used to close the rectus at the end. This is called as Hassan's technique. If you will not close it, hernia is unavoidable. It is approximately 10 to 20% cases hernia will develop. If you do not have Hassan cannula, you can use your simple cannula without trocar, but for that you have to give a purse string suture, because if it is not cone shaped, gas will keep on leaking. So, you have to give few stitches around it. If you are doing diagnostic laparoscopy under local anesthesia, then IV sedation is must. We should insert the Veress needle perpendicular, and slow insufflation should be used, otherwise your patient will jump, will cry, because a rapid stretch of the peritoneum patient cannot tolerate. So, slow pneumoperitoneum should be given, and pressure should not exceed more than 8 millimeter of mercury, because patient is breathing her own, patient is not ventilated, he is not on the ventilator. So, if you will put more than 8 millimeter of mercury, there is a problem. In obese patient, you have to be particularly more careful that you should go perpendicular, and you may ask your assistant also. Sometimes you have to clear the subcutaneous fat, and then you should know that how much fat patient has by putting your small finger, and then you should put the trocar and cannula perpendicular. Always try to see the when the trocar goes in, otherwise if there is any adhesion, it can damage it and you will be in trouble. Sometimes you have the specialized instrument like optical needle and optical trocar. The Star is making a Veress needle, that is called as optical needle. In that there is a fiber optic, and theoretically you will see while going in, but practically nothing is visible. VG port is good, that is a optical trocar which has a blade and which has a telescope you can introduce in. VG port cost is 35,000 rupees, and it is a completely disposable. You have to take it out. This is the optical trocar and this is cannula. Now, you give a incision 11 millimeter incision, and after that you will press and then you will fire. Put the telescope inside, 0 degree telescope is better. And support it and fire. With each firing, a blade comes, here you fire, and through this is the blade which comes. With each firing, this blade come in out, and it enters into the abdomen. So, it is an expensive way of doing the access. If your patient can afford, it is the cutting the facial layer, cutting the peritoneum, and sometimes cuts the bowel also, and then you enter into the inside, and then you can introduce your telescope, you can start your surgery. So, this is visiport. Fielding technique is also sometimes used, in which you can inject a lot of saline and you can do the ultrasound, especially in extensive adhesion, to find out the pockets of the adhesion. There is one Turnamian technique. This is called as Turnamian trocar. In this, there is a blade in the cannula itself, and here it is a sharp blade at the tip, and it is threaded. So, you just put it and keep on rotating the cannula, just like how you are drilling the earth for digging the water, it will enter inside. Turnamian was one of the surgeon who has invented it. On his name this is called. Another is step trocar. A step trocar has a stretchable single use. You cannot use next time, because it get completely, it break and it get loose. You cannot use it next time. And even the 3 millimeter cannula trocar can be diluted up to 10 millimeter. You can step by the step, that is why it is called a step, 3 to 5, 5 to 10. And you can introduce, first you will, this is a needle, and first you will introduce this trocar, then remove this needle from here, and then in over this sleeve you will put the other trocar, and the sleeve will stretch. So, you do not have to repair the port, hernia chances are also less, because incision is actually only 3 millimeter and the trocar is 10 millimeter. Some people they say it has one drawback, that margins has a ischemia because of excessive pressure over the tissue on the margins. This is a step trocar, how it breaks and how it stretches the. This is strictly disposable. So, very good in the country where they always use disposable, for them it is good. You should also learn how to do tap block. If you are planning to perform the day care laparoscopic surgery, then transversus abdominis plane block is very important. You know, all the sensory nerves of the abdomen is coming through the transversus abdominis nerve branches, and by the ultrasound you can do the tap block. So, you can discharge the patient post operatively after a few hours only, and you do not need to give any analgesia after surgery. No analgesia is required. So, what to do? This is the ultrasound, and ultrasound will show you all the muscle and the different, this is the different muscles layer. Here is the skin, this is external oblique muscle, this is internal oblique muscle, this is transversus abdominis muscle, and this is the plane of the transversus abdominis plane. At this plane you have to inject the needle with the lignocaine and xylocaine, and after that do the surgery. Patient will not say, I do not have at all any pain after surgery.
But this is not the neurovascular plane or the visceral nerve.
Pardon?
This is not the neurovascular plane. Neurovascular plane starting posteriorly.
No.
And the tenoid.
Yes, that will give you the anesthesia about the port wound.
What you are speaking, if you are near to the rectus sheath, yes, it will be received the rectus sheath, then coming anteriorly and divided into lateral and medial branches, subcutaneous.
Yes.
So the plane mainly start in the plane between the transversus abdominis and the internal, and not the below the transversus abdominis.
Yes, but what is there? Once you give the, at that plane it has a pocket to retain the xylocaine, and after that entire layer is anesthetized. So, this is the plane here. How to do? We will see that. Here you have to start the ultrasound, and this is a spinal needle which is going slowly under vision, and it will enter. Right now this is external oblique, now it will go to internal oblique, and then you will go to the transversus abdominis plane. tap block is nowadays gaining the importance for the daycare surgery. In the daycare surgery, anesthetists, our anesthetists are charging little more 2500 more for doing the tap block, because they have to learn separately, because every anesthetists are not good in ultrasound. So, here they have to learn the method of finding out the plane, and now it is come. Here is the needle, and now it is coming at that level. And then you will see it will start blebbing. Now it is blebbing. Can you see that? It is blebbing, and then the fluid will start going to this area. Before giving incision,
I think this is the distance, is the vein between the transversus and internal vein, and not between the peritoneum and the internal vein.
no, it is not in between the peritoneum, it is transversus abdominis plane.
The internal vein.
Yes, and now you will do the procedure. So, this is a good technique if you want. Otherwise, if you do not want tap, then also if you want post operative less pain, you can inject the subcutaneous xylocaine before giving incision, because initially only if you will inject the xylocaine or lignocaine, then the inflammatory chain is not triggered, and then by the end inflammation is completely stopped. Some people at the end of anesthesia they inject the xylocaine over the skin. In that the problem is already inflammatory reaction, serotonin, bradykinin is already secreted, and now it is less effective. So, in the beginning only injecting xylocaine is better before incision. Now, the complications. Chandler has done one study that is very famous as Chandler's study. Any question?
Yes, sir. So I wanted to ask, when we have to change the position, tilt the patient head low, at what point we should do?
Do you know, if you are a gynecologist, you always from the beginning only it will be head low, initially 15 degree, after that 30 degree.
After trocar insertion.
After trocar insertion. And if you are a surgeon, then you have to put head up after trocar insertion, after primary trocar insertion, after primary trocar insertion. So, according to Chandler's study, who has done in 2001, this is the incidence of injury. He has done a study of 10,000 patients, and 51.9% of all the complication which happens in laparoscopy is a small bowel injury. And in 10,000, 148 cases, means 1.4% is the average incidence of the injury of the small bowel. Then colon, then urinary bladder, then liver, then stomach. So, suppose you went inside the abdomen, and if there is any yellow area anywhere in any flank or any quadrant, you should immediately be careful, and then you should do little diagnostic, like putting the bowel out, and then you should try to find out, and here is the perforation. Now, what to do? You should put a gauze piece and wipe it out, and you should do primary closure then and there. You should not spend time to let this fecal matter come out and contaminate other area. So, immediately we should close it, and localized cleaning should be done, thorough lavage should be avoided, otherwise this infection is going to the other quadrant. Another injury is very common, is the needle injury, in which iliac vessel, mesenteric vessel, aorta, abdominal, but advantage of the needle injury is this is a suture passer which has injured. It could be the Veress needle. Most of the needle injury is self limiting, it get immediately itself it get stopped, and you, if you feel that it is bleeding still, you can bring a atraumatic bipolar, atraumatic grasper, lift the momentum, and with the bipolar or ligation or with the suture or endoloop with the pre-tied extracorporeal knot, you can tie a knot and bleeding will stop. Sometimes trocar site injury, like here the blood is coming over the liver and from where it is coming? It is coming to this area, this port site, and here is the bleeding. So, with the heel of the hook you can try to coagulate, and bleeding, that is bleeding is stopped. But if it is not coming back, if it is still bleeding, then you can put a suture passer and you can fix a transfacial, and you can subcutaneously you can tie the knot. Otherwise, what you can do? You can take a Foley's catheter, put a Foley's catheter inside, inflate the balloon of Foley's catheter and pull it out and strap it somewhere. So, it will give you pressure like a tamponade, which will stop the bleeding.
So with bipolar also
Bipolar also
we can
you can do. Robbie dissector you can do. Another type of injury is inferior epigastric injury. That is very important, that if you are going it, you should do trans illumination, because it is variable. Remember, just remembering the anterior superior iliac spine and not going to help you, because these branches of inferior epigastric vessel is variable in the surface marking. So, better always you see it by the trans illumination. It does not matter how much obese the patient is, inferior epigastric 100% of the time you can localize. How to localize? I will demonstrate you. Here you can see this is a bladed trocar, and there is a track. In the track your skin incision was correct place, but because you have a tendency of going oblique, you did not go perpendicular. So, your skin entry is here, but you are going over the inferior epigastric vessel, and it has cut the inferior epigastric vessel by blade, and it is bleeding now. This is direct transaction of inferior. Immediately put the finger there, take the trocar out and introduce your finger to pressure, and finger is stopping the bleeding, although still it is little bleeding, and then you can use a transfacial fixation. Here is a bipolar Robbie dissector. With the bipolar you will try, but it did not stop with the bipolar. Then what you can do? You can do the suture passer, and you can pass the suture percutaneously, and you can give like a cross. This is suture passer with the vicryl. This is the vicryl. Hold the vicryl, and from other side again pull the vicryl out and tie a knot and make a plus sign, one like that, one like this. So, that from any direction if the vessel is there, it gets sutured, and then you tie it, and then you go to the plus sign. So, this is also very common injury in cases of gynecological practice, because of not seeing the inferior epigastric and putting the port at wrong plane or making a track. Here is the, you can see this is the deep ring, this is round ligament, and if this patient is male, this is vas deferens, this is spermatic vessel, and here is the inferior epigastric vessel coming. Surface marking also we have to, yes.
in suturing this we should go through the skin or through the
No, through the rectus. Skin should not be included, otherwise it will not give you that much pressure and you have to cut the stitch. But if you will leave the skin, it will be absorb its own. So, this is now taken, and again other side. So, it is require a lot of effort to pull it and then give the pressure over the abdominal wall and then tie it. So, ideally we should not do this type of mistake. Pardon? This? Okay, figure of 8, no, figure of 8 you can make, but generally it should be cross one over another and interrupted. It is all interrupted, you cannot do continuous with the suture passer. Other complication is gas embolism. Gas embolism is 1 into 1000, but mortality rate is 1 into 10,000 to 1 into 60,000. Other complications are pneumoomentum, surgical emphysema and pneumomediastinum. Pneumoomentum, surgical emphysema and pneumomediastinum, these also has to be taken care of. Pneumoomentum, like you will see a crystal like ball inside the abdomen, because some gas has entered into omentum. Surgical emphysema in the elderly people more than 70 year of age group, surgical emphysema is common, because their percutaneous, the subcutaneous plane is very lax, parchment like skin. So, gas enters. If it is happening in adult, that means your pressure is more than 25. Pneumomediastinum is a condition in which there is a small opening into the mediastinum, that is a congenital defect, and with every movement of the diaphragm some gas is going into the mediastinum, but it is not returning back into the abdomen. So, it acts as a tensor pneumothorax, and then patient will get a lot of tubular black shadow you will see due to the pneumomediastinum. So, immediately surgery should be stopped and patient should be artificial ventilation for few hours. CO2 is so fastly absorbed gas that it will get absorbed its own. So, these were few of the complications. Most of the time the complication happens due to chain of error, like here surgeon is not putting the index finger pointed, he is pressing the abdominal wall from both the hand, dimpling the abdominal wall, pointing towards the aorta, it is not going, dimpling again, and now he is not sure how to do, and he is holding like this now. So, these type of errors must be avoided, otherwise we can kill our patient. So, thank you very much.